Hello, everybody. This is Marie-Claire Seeley. I'm the CEO of the Australian PoTS Foundation, and I'm really pleased to be here today to present to you about Australian research in postural orthostatic tachycardia syndrome. So I'm just going to share my screen and hopefully you can see that. So essentially, I just want to first let you know that I have some disclosures, and that is that the Australian PoTS Foundation does receive support from many different companies, and that helps us to continue our work to support our community. So here in Australia, we have a similar problem to what everybody else in the world experiences, and that is that we don't have much data around PoTS and how it affects people and how many people have that condition. And this primarily relates to the fact that many countries have not had an international classification of disease code for PoTS, and that's the same here in Australia. We actually have just had that code accepted in July 2025. But prior to this, we have not had a code. And this has meant that there has been no data that how many people in Australia are affected, how often they enter hospitals, how much it impacts their quality of life. And this has largely meant that clinicians in Australia have been unaware of the condition. And it means that our health departments have not been able to plan or fund for helping people with this condition and providing appropriate health services. So because of this problem, the researchers here in Adelaide about 5 years ago, we decided that we would start a study where we started a patient registry. It is now one of the largest patient registries, certainly the only one in the Southern Hemisphere. So back in May 2021, we started enrolling patients into a registry. And today I'm going to show you data from this registry. I think it's important to let you know, first of all, that this is essentially patients who saw us at a private care clinic. So that has an effect on the demographic of patients that we see, and we need to declare that up front. We use the international criteria for diagnosing PoTS, as with most patient registries. And we recruited people who were 16 years or older and who consented to be engaged in the patient registry. I also want to let you know that we collect what we call patient-reported outcome measures, which I'll often refer to as PROMs. And the most common of these is the composite autonomic symptom score. We use this a lot in our research because it looks at autonomic symptom burden across multiple domains. It's not specific to PoTS, but it's a very useful tool. And higher autonomic symptom burden means that you have higher scores on the compass, 31. We also use a lot of data out of what we call the EQ5D5L. This is a very commonly used quality of life measure, is used across multiple disease states and all over the world. And from this measure, we can derive what we call a utility score. And a utility score ranges from 0 to 1, with 1 being full health, 0 being a state of health that's equivalent to death. And in fact, there are states of health that are considered to be worse than death, so lower than 0. We also sometimes use the fatigue severity scale, and we often look at gastroparesis symptoms. So they're symptoms of the upper gut. So you hear me refer to these things along this talk today. So I'm going to give you a brief oversight of several of our studies that we have used out of the Australian PoTS registry. So the first one that I want to talk about is our first study that we did on quality of life in PoTS. It's obvious to anyone who lives with this condition that quality of life is poor, but again, our health system didn't know that. We didn't have much evidence to support that claim. So we decided to undertake a study where we compared the health-related quality of life of individuals with PoTS to what we call a normative population. So this is a group of people in South Australia where we live who had undertaken the same survey, the EQ5D5L, and were just general people in the population. And there were several thousand who had undertaken this study. And therefore, we were able to do what we call matching. So we were able to get normative people who were the same age and the same sex as those individuals who had PoTS, who had also undertaken this survey, and then we could compare essentially like for like. So people who were out in the community, the same age and sex as our PoTS patients. If you want to read more about this study, you can find it in Clinical Autonomic Research. Just very briefly, what this study found was what we all know, and that is that PoTS has very low quality of life, but it was surprisingly lower than what even we thought. So we were able to use that utility score to compare PoTS to other chronic health conditions that use this score to measure quality of life. And you can see here on this graph that in the far right-hand side are the normative population, so people who we don't know what their health conditions were, but they're just from the general public. And they had a quality of life that was almost 1, so quite high. And then you can see that there are a range of conditions with utility scores that go down the graph. So people with HIV, diabetes, cardiovascular disease, chronic obstructive pulmonary disease, neoplasms or cancer, chronic kidney disease, and at the very end on the left-hand side of your graph are people with PoTS. So the quality of life is very low there. It's a utility score under 0.6, which is really a very, very low quality of life. And in fact, the only other health condition we could find with a lower quality of life, and it was only marginally lower, was people who are living with multiple sclerosis. So we established, off the bat that the quality of life was quite low in PoTS. But we wanted to understand a bit more about whether sex differences impacted in PoTS. So what were the experiences of both symptoms and the journey of diagnosis for people who were male and female, and was it different at all? So we undertook this study looking at 500 participants in the registry, and we published this in the European Journal of Cardiovascular Nursing if you'd like to have a look at the study. So here on the right-hand side, we have a graph that shows us really the outcomes of the study, and that was that we found a lot of similarities. So men and women had very similar experiences in terms of the onset age of PoTS. So they found that their symptoms started around the same time. They sought healthcare the same way. So men went to emergency departments the same amount of time as women. They sought as many specialists out for diagnosis as women. Their quality of life was reported as being the same impact on their health, the same impact on disability, their same impact on social withdrawal, their ability to work. Their symptoms were similar in terms of fatigue, anxiety, and depression. There were no differences between males and females. But what was the differences that we found? We found that women had a lot higher autonomic symptom burden than men, and also their diagnostic journey was a lot longer than men. So in Australia, it was 7 years for a woman to be diagnosed compared to a male of 4 years. They were 2.7 times more likely to have a diagnostic delay greater than 10 years. Men were more likely to have concussion onset PoTS. Women were more likely to have their symptoms attributed to anxiety before diagnosis, and women were also more likely to be offered a mental health care plan rather than a chronic health care plan than men. Then we went on for another study to look at what we saw as a rapid increase in presentation of people with post-acute sequelae of COVID-19. So we really started this study back in early 2021 when we saw a lot of PoTS presenting as a result of COVID-19. So post-acute sequelae of COVID-19 is commonly referred to now as long COVID. And we undertook a study to compare people with long COVID to people with PoTS and healthy controls, so people that had no other disease states. We took 33 people and for each cohort, and we compared essentially their autonomic symptom profile and their diagnoses and their quality of life. And if you want to read more about this study, you can read it in the American Journal of Medicine. It was published online in 2023, but has only just been published in 2025 in print. Suffice to say, when we look at the autonomic symptom burden, if you look at this graph, and this is the compass score, so the further out to the edges that the colour goes, the higher the symptom burden. And we can see that people with PoTS in the orange there had very high symptom burdens of pupillary motor, orthostatic intolerance, vasomotor, so that's the redness that comes into the feet and the hands. Gastrointestinal symptoms were also predominant. People with long COVID also had a lot higher symptom burden than the healthy controls, but it wasn't quite as bad as those with PoTS. And that possibly is because some of the people with long COVID did not have PoTS. When we took them out of that cohort and only compared people with long COVID with PoTS to other people with PoTS, we found that they looked almost indistinguishable in terms of symptoms. Here we have the quality of life scale, and we can see that people with long COVID in the purple had significant issues with undertaking their usual activities. And this was actually worse than people with PoTS. And we suppose or theorise that that might have been because for the people with long COVID, this was a new chronic condition. But for people with PoTS, they'd actually lived with their PoTS for nearly 6 years at the time of doing their testing. You can see there that in the orange, people with PoTS had a lot higher pain and discomfort many years on from developing their condition. In the end, we found that nearly 80% of people with long COVID met the diagnostic criteria for PoTS. However, that was in a very small cohort, only 33 people with long COVID. So we did go on to look at a larger cohort, and this slide is unpublished data, so please don't share it around, but so that you understand what we have found and hopefully we'll publish, is that 98% of people with long COVID met an autonomic disorder diagnosis. So either PoTS, initial orthostatic hypotension, or classic orthostatic hypotension. And you can see there that PoTS was the most common diagnosed autonomic disorder in the long COVID cohort of 150 people. Study 4, we went on to look at cerebral hypoperfusion, and this is a study that I know a lot of people have had interest in. So we looked back at our PoTS registry and we looked at how many people had what we call a brain SPECT. And this is a CT where they use a injectable radioisotope to track and trace the blood flow in the brain and see where there are areas where blood is not reaching where it should. And so we refer to this as cerebral hypoperfusion. So this is published in Nature Scientific Reports if you'd like to have a look at the full study. Essentially, in this cohort, we found there were 56 people who we had access to data for their brain SPECT. The majority of them, well, the average age was around 30. They were mostly tertiary educated, mostly female and Caucasian. And on average, they'd had their symptoms for around 5 years. Many of them couldn't work due to their PoTS. We also looked at the trigger for their PoTS because we wanted to see if that affected cerebral hypoperfusion. And you can see that the majority of people that we looked at had PoTS onset from COVID infection, and there were some who had onset from other infections, and about 13% had PoTS from concussion. 10% were from other triggers or unknown triggers. So in terms of results, we found 61% of people who had had a brain image had low blood perfusion of their brain. And of those 61%, 67% had multiple, so more than 3 or more areas of the brain affected by cerebral hypoperfusion. I would also say that 39% that didn't meet the strict cutoff for cerebral hypoperfusion had very low normal brain perfusion. So even those that were deemed normal were very close to being abnormal. Just so that you can understand visually, this is what a cerebrally hypoperfused brain looks like. So here we have the frontal lobe area, those patches of yellow and red are showing cerebral hypoperfusion here and also back at the top of the sensory motor area. And if we compare this to a normal person, so a person without PoTS, who's 33 years of age, you can see what a normally perfused brain should actually look like. We undertook what we call a regression analysis, and this was to try and figure out what actually predicted the reduced quality of life in this cohort. So we did find the quality of life in people with low cerebral perfusion was very low. And we found that the number of brain regions affected, so the more brain regions that were affected, the more or the higher your composite autonomic symptom score and the higher your gastroparesis symptom score, so the higher the symptoms, the worse your quality of life. Those three things predicted that your quality of life would be low. And this is really the summary of what we found in that study, that there was a high prevalence of cerebral hypoperfusion that predominantly affected the frontotemporal areas of the brain as well as the sensory motor area. And we found that those GI symptoms or the gastrointestinal symptoms, the autonomic symptoms, and the number of regions predicted quality of life, and that this didn't differ according to the trigger. So it didn't matter if it was COVID that caused your cerebral your PoTS, or if it was concussion that caused your PoTS, you still had the same apparent risk for cerebral hypoperfusion. So the last study that I want to look at is a study of 500 participants that we also looked at symptom burden and diagnostic journey, and essentially what autonomic function looked like in this cohort. So this was a general study, and it was really to compare that and to show what it looked like in Australia. As we saw in the sex discrepancy studies, you know, the average age was what we report internationally, mostly female, mostly Caucasian, 31 years average age. 55% presented to emergency departments at least 5 times prior to diagnosis, and they consulted multiple specialists prior to diagnosis. 22% at baseline were unemployed or unable to attend education, and 26% of this very young cohort said that they couldn't socialise more than once a month. Diagnostic journey was similar to what we've seen internationally. So the onset of PoTS was in the young 20s, so around 23 years of age. 56% had their symptoms onset at adulthood. Even though this is often considered an adolescent disease, it is not the case. A lot of people develop this in adulthood. As we've already said, long diagnostic delay. In fact, 26% of Australians with PoTS waited greater than 10 years for their diagnosis. 65% had their symptoms attributed to anxiety rather than PoTS. And this last slide really shows us what I've talked about throughout, which is the autonomic symptom burden, which is broad spread, really correlates to reduced quality of life. So here you can see the compass score on the bottom there. The closer the compass score got to 100, the lower the quality of life. So that effectively shows us that there is a direct correlation between higher autonomic symptom burden and reduced quality of life in PoTS. So in conclusion, all these studies, which I've only shown you very briefly due to time, show us that in Australia, our research really confirms that diagnostic delay is very long, that health interactions are increased in this population, that there is an association with infection in onset, both COVID and other infections, that the symptoms are multisystemic. So autonomic symptom burden is broad spread. It's not just cardiovascular. There's high unemployment and social withdrawal in a very young population. And quality of life is really associated to all of those different factors. And here is our research team in Australia, and I just want to thank all of them. This is a very small team, but we've put out a lot of research in the last few years, and without them, we wouldn't have been able to get this work done. So I just want to really thank all our research team, and I want to thank the conference organisers for reaching out to me. I would love to be able to come over one day and present in person in Germany, and I'll be very pleased to engage in your question time. So thank you very much.